Hello, this is Amir Shoaib from the Orthocycle Foundation, and I'm going to talk to you today about Hallux Valgus. The various aspects of Hallux Valgus that we're going to talk about include definition, the etiology, the anatomy. We're going to learn classification for the exam, talk about relevant investigations and the different treatments that are available. Let's start off with the definition. Unfortunately, there isn't a good definition for Hallux Valgus, so this is what I would describe it as. So it's a pathological lateral or valgus deviation of the phalanges of the great toe, which is often accompanied by varus angulation of the metatarsal of the first ray. The bunion itself, the prominence, is actually the metatarsal head, which is being pushed out medially by the varus angulation of the metatarsal and also by the valgus angulation of the phalanges. Some people call it a bunion, some people call it a hallux valgus, and other people call it hallux abducto-valgus. We know that it affects women more than men. It's a condition which is inherited in over half of cases. There's a strong family history, but it's not a single gene that causes the hallux valgus. There are anatomical variations which might account for the metatarsus varus. It affects any age, although in children there may be different means of the hallux valgus occurring, and it's often associated with hypermobility of the TMT joint, which is again possibly related to its anatomy. Let's have a look at this. So if we look at the tarsal-metatarsal joint of the first ray, in patients who've got one or two facets, they're much more likely to develop hallux valgus because of relative instability, but those with three facets are much less likely to develop hallux valgus. If you look at the sesamoids essentially on an x-ray will be in the position that they should be, and it's the metatarsal head itself which has moved, so it's relative movement of the metatarsal head in a medial direction and the sesamoids in a lateral direction. The tendons on either side will rotate, and unfortunately this results in a torque, and the metatarsal head can then pronate, and the sesamoids can then become adherent to the side of the metatarsal neck. The extrinsic tendons, which are normally well in line with the metatarsal and the phalanx, can bowstring. So as the hallux valgus occurs, the tendons may actually make this worse. The adductor tendon is attached to the proximal phalanx and the sesamoid articulation, but in itself may not be actually contributing towards the hallux valgus, although quite commonly during surgery it's divided to try to aid the reduction. When you do the exam, it's useful to have a classification on which to base your treatment options. And this is a simple X-ray classification: mild, moderate and severe. And this is determined by looking at the hallux valgus angle, which is angle A, the shaft of the metatarsal and the proximal phalanx, and the intermetatarsal angle, angle B, which is generated by drawing a line down the second metatarsal and the first metatarsal. Another interesting angle to look at is the distal metatarsal articular angle, which is basically generated by drawing a line along the edges of the articular surface on the metatarsal head, and also drawing a line down the shaft of the metatarsal bone. And essentially the angle should be less than 10, but if the articular surface is lopsided, so it's slightly more valgus, then this could account for a hallux valgus deviation. When you look at your classification, if you play tennis, then you already know this. So a hallux valgus angle, that's angle A in the picture, 0 to 15 is normal, 15 to 30 is mild, 30 to 40 is moderate, and more than 40 is severe. Looking at the intermetatarsal angles, angle B, 0 to 9 is normal, 9 to 13 is mild, 13 to 18 is moderate, and more than 18 is severe. Sometimes this can be a little bit confusing because all the metatarsals might be pointing into varus, and so you may not have a very big intermetatarsal angle, but you may still have quite a generous hallux valgus angle and a prominent bunion. And as I said before, the DMMA, distal metatarsal articular angle, should be less than 10 degrees, and if it's more than 10 degrees, then it suggests that the articular surface is not on the end of the metatarsal, but more eccentric towards one side. When you examine the patient, you need to take a decent history, and usually what patients complain of is pain over their bunion and it's rubbing on their shoe. They find that it becomes more and more difficult to find shoes that fit because of the shape of their foot and the width of their forefoot. If it's been rubbing for a long time, then the area can become red and even ulcerated. Because the first ray is defunctioned because of the hallux valgus, they often overload the lateral rays and they can develop lateral ray pain, metatarsalgia, such as Morton's uroma type pain. Sometimes you see crossing over of the toes. You'll always have to look for a family history, and you'll have to ask about whether any other joints are affected, because they may have an inflammatory arthropathy, and you might want to change your treatment on the basis of this. It can't be avoided that there's a degree of cosmesis in the patient's consideration and presentation, but most patients who do present are presenting because of pain. When you do any foot and ankle examination, you'll want to do a silver scales test to look for any gastroc tightness. Hallux valgus can be associated with inflammatory arthritis and with pes planus, so it's worthwhile looking for these. You might need to look at their hands and their face in order to establish that they've got other signs of rheumatoid disease. Looking at the foot, you might discover that they've got a prominent bunion. As well as the hallux valgus, you might find that there's pronation of the great toe. Sometimes you can see an interphalangeus deformity because they've got a cuneiform shaped proximal phalanx. If you look at the lateral side of the foot, there may be bunionettes, which is essentially the fifth metatarsal equivalent of a bunion. You might have crossover toes. You might find callosities. Hard callosities are those which are between the foot and the shoe, and soft callosities are generally where the one part of the foot is rubbing on another part of the foot. It's worth establishing if there's TMT hypermobility, although this isn't something that necessarily needs to be addressed. It's worth checking to see whether the deformities can be corrected, and as there can be some degenerative change within the joint if it's been present for a long time, then it's worth doing a grind test to establish if they've got osteoarthritis, because this again might change your management. Another test which I find useful is to take the patient's shoe and draw a line around the shoe and then get them to stand on it, and that will indicate whether they are actually wearing shoes which have got too narrow a toe box or too narrow a fitting to accommodate their foot, and if they've got a pointy toe box on their shoe, then this may be exaggerating the deformity. As with any foot and ankle examination, you want to check for sensation and vascularity. The routine investigations that I would ask for include weight-bearing x-rays, an AP, an oblique and a lateral. If you're worried about the sesamoid articulation being degenerate, then it's worth getting a sesamoid view as well. Now, if you look in the literature, there are two real ways that you can treat hallux valgus. One is by accommodating this by having wide toe box shoes. You can wear a splint, but the splints are only effective in controlling the alignment while the patient's wearing them. And of course, patients want to be free of splints if they can. Now, orthotics and splints are sometimes sold as devices to cure hallux valgus, but unfortunately they don't cure it. All it may do is offload the first ray a little bit, but there's a Cochrane review which basically says The options for treatment are either wide toe box shoes or surgery, and nothing else is going to be a reasonable treatment that's cost effective. So if you're going to offer surgery, essentially what we're going to do is excise the medial eminence, although we're not going to go as far as the sulcus because this can lead to complications, and you need to perform an osteotomy. And we had a classification system described earlier, and this translates to the type of surgery that you're going to offer the patient, and this is the best approach to use for the exam. So if you've got a mild deformity, then you might offer the patient a chevron. If you have moderate deformity, you can offer a scarf, and if you've got severe deformity, you'd offer a basal dome osteotomy or a Lapidus Fusion. In reality, it's not as straightforward as this, and some people use a scarf for every bunion operation, and some people use a chevron for every bunion operation. It depends on the individual and other factors. So what are we trying to do when we offer a patient surgery? Well, we want to correct the intermetatarsal angle, we want to correct the hallux valgus angle, we want to correct the pronation, we want to avoid stiffening the great toe MTP joint, and because the first ray has been defunctioned, we want to try to plantar displace the first metatarsal so that it's weight bearing again. We want to try and get the metatarsal head over the sesamoids, and overall we want the foot to be shoeable. We want it to be able to fit into a normal shoe. If you've got other clinical problems with the lesser rays, then these can be addressed at the same time as the first ray surgery. So let's have a look at these angles again. So first of all, we're going to try and correct the intermetatarsal angle. This is essentially what your first metatarsal osteotomy is going to do. So your chevron, your scarf and the basal and the lapidus are essentially moving the metatarsal head in a lateral displacement so that it decreases the intermetatarsal angle. Once you've done that, if you've still got a deformity, i.e. hallux valgus angle, then this needs to be addressed by an Aetian osteotomy. If you have a pronation of the great toe, then the Aetian osteotomy can actually be used to rotate the great toe phalanx as well, so that the nail plate is pointing upwards as normal. When we want to move the metatarsal head laterally, we need to release them from the sesamoids, especially if they're being adherent to the side of the metatarsal. And this is what your lateral release is going to do. Ideally, you just need to release the suspensory ligament. Many people release the adductor tendon, but it's been shown that this doesn't actually contribute. We want to try and make the great toe weight bearing again, and this can be done with the osteotomy by depressing the metatarsal head. It's important that we avoid stiffening the great toe MTP joint, and this means that you want to get bony correction so that your soft tissues can remain lax, so that you maintain your range of movement at the MTP joint. There are some people who use capsular advancements with the VY, or they plicate the capsule. All this tends to do is tighten up the MTP joint and limit the range of movement, and when the patient forces their way through this by forcibly dorsiflexing, it stretches the capsule out again, so any capsular correction is going to be lost as the capsule stretches again. And although we know that there's TMT laxity which might be responsible for the varus of the first metatarsal, this tends to settle no matter where the osteotomy is. So even if you do a distal osteotomy, the TMT hyperlaxity seems to settle. Let's talk about a few of the osteotomies. So this is a chevron osteotomy. It's used for the mild deformity, as we said before, and the first stage of the operation is essentially removing the medial eminence and then releasing the sesamoids on the lateral side, the suspensory ligament, and then you can form a chevron cut, which is a V-shaped cut. The metatarsal head can then be translated to cover the sesamoids, and then a screw can be put in order to maintain that position. Now, the old-fashioned way of performing a chevron osteotomy was with a V shape, but the problem is that the bottom leg of the V comes out where the sesamoid articulation is, and also there's a prominent vessel on the medial side which needs to be maintained as this supplies the metatarsal head. So for a chevron osteotomy we now tend to use a modified osteotomy which has got a longer inferior leg which avoids the articulation and also avoids the feeding vessel. Once the chevron's been performed, if there's still a hallux valgus angle, this needs to be corrected with an Aetian osteotomy. The scarf osteotomy is a very powerful osteotomy. It can be used for any type of bunion, mild, moderate or severe, and essentially you start off in the same way as the chevron by removing the medial eminence, and then the sesamoids are released on the lateral side. Now the cut is slightly different from the chevron because it's a Z-shaped cut, and this is what gives it its versatility. You can translate the metatarsal head on its own, or you can translate it and rotate it in the axial plane. And if you look at the bottom diagram on the left, you can see that if you choose the angle carefully, that you make your transverse cut in the metatarsal shaft, as you translate the metatarsal head, you'll actually depress the metatarsal head as well. So this will make it more load bearing. So it's held with 2 screws just to prevent any rotation and to ensure that we get good union, which usually occurs. And the Lapidus Fusion is really reserved for severe deformities. The operation is occurring at the TMT joint, but actually it needs soft tissue release both medially and laterally around the metatarsal head, so it's quite a big soft tissue incision. So the incision allows you to perform a closing lateral wedge either outside the joint for a dome osteotomy or inside the joint for a fusion, and this can then be secured to give you a smaller intermetatarsal angle. This is going to drag whatever hallux valgus you've got and actually make it worse in its clinical appearance, and so you've got to be quite aggressive with your Aetian osteotomy in order to get the toe pointing forwards again. It's also absolutely necessary to release the sesamoids in a sling from the medial side and the lateral side in order to allow the metatarsal head to drift back over the sesamoids themselves. In some patients, especially with sort of quite severe deformities, you might find that their distal metatarso-articular angle is increased because the articular surface is on the lateral surface of the metatarsal head rather than being on the end of the metatarsal head, and this is very common in younger patients as well. So there is a risk, if the crista is still present, that if you derotate the head using this kind of osteotomy, you might cause them more pain. But in the elderly, the crista is usually eroded, and so it's quite safe to derotate the head. It's essentially a closing wedge osteotomy to move the articular surface to the end of the metatarsal head rather than being on the lopsided. And if this is done aggressively, you can actually avoid needing to do an Aetian osteotomy as well. If we look at the outcomes, generally patients are very satisfied with the results of surgery. So with the chevron, which is for a mild deformity, we expect at least 80% excellent results. The scarf osteotomy, you'll still have 90% excellent or good, but there's still a minority of patients who are unhappy. With basal osteotomies, it's actually quite a tricky operation to perform technically, and you can still offload the metatarsal head if you haven't depressed the metatarsal head, and so patients can still develop metatarsal pain on the lateral side of the foot, which is transverse metatarsalgia. With a Lapidus, again, you're going to shorten the first ray, so you might be worried about transverse metatarsalgia, and there's a small risk of non-union as well. There is some subjectivity in the way that patients respond to surgery. So some patients for whom, especially for whom cosmetic results are important, may find that you may find they're not as satisfied as many other patients who are actually more symptomatic from pain. Now, we can't really just talk about surgery for hallux valgus without mentioning minimally invasive surgery. So the reason that this is performed is not just because of cosmetic reasons, because even though it's performed through small stab incisions, which are only 3 or 4 millimeters wide, wounds on the medial side of the great toe actually heal up very well. The big difference is actually that they seem to have a lot less pain and they have a lot less swelling post-operatively. When you perform an osteotomy, the patient's still going to take 6 weeks for their bone to unite. There are people who actively discourage patients from having minimally invasive surgery because they mistakenly believe that it's not suitable for severe deformities, but actually you can perform minimally invasive surgery for any type of hallux valgus, mild, moderate or severe, and it's certainly effective. And I would recommend it for patients who especially are concerned about what they may have heard about the degree of pain that patients suffer after open surgery, where all the soft tissues are stripped off the bone prior to the osteotomy. This type of surgery is performed with a small burr, which is only just over 2 millimeters wide, which cuts sideways, and it allows the whole operation to be performed through stab incisions, and it doesn't involve stripping of the soft tissues. So I hope that we've covered our objectives, which are we've had a stab at a definition. We've talked about the etiology and the anatomy and what can go wrong. We've learned a classification that will be useful for the exam. We've talked about the relevant investigations and the different types of treatment. Thank you for your attention.